Newsfirst News with Faraz Shauketaly.
Hello, good evening and a very warm welcome to Newsline Zoom. Zoom because we're taking extra precautions due to the rising number of positive cases and also the rising number of the death toll in Sri Lanka thanks to the COVID-19 pandemic. Our guest this evening is Dr. Manuj Weerasinghe, who is the head, the Department of Community Medicine, the University of Colombo. Very good evening to you, Dr. Manuj.
Good to be here.
Thank you. Dr. Manuj, yesterday we had the positive figures at just over 3,600, and also the death toll yesterday was 171. What are we doing wrong, or what should we be doing that we are not doing?
If I can briefly explain a few things before stating what we need to do or what we need not do. Yeah. When we are talking about official figures that is being published by the Minister of Health, around 3,000, 3,500, our general estimates from our understanding of epidemiology is that there should be more than 3 times of what is published getting infected daily in the community, which means my general understanding now from our own calculations is at least we are getting 10 to 12,000 cases getting infected in the ground in a daily basis at this rate. The dynamics of transmission has to be looked at, because what we find is what we have been tested. But there are many others in the ground who have not tested for a couple of reasons. One is people may not present for testing. Second, the sample that we select for testing is also not a totally representative sample of all who are getting infected. So, our general calculations, there are mathematical ways of calculating. From my understanding, we have at least 10 to 12,000 cases getting infected per day. That is one. When you are looking at deaths, I think I am not surprised at all to the number of deaths that we are seeing today. Which means the deaths that we are seeing today or yesterday of 171 are those got infected at least 2 weeks to 3 weeks before, which means sometimes it is the late July. Those who are infected are getting serious disease later and unfortunately dying of COVID. That is what we are seeing today, which means at that time, we generally expect the case numbers to be actually around 3,000 or so. So for that particular case number is the deaths that we are seeing. But the next question you ask, what's happening and what we have to do. Now, as I told you very clearly, we expect that at least 10 to 12,000 people are getting infected. So if you look at the current death rates, so in 3 weeks' time, possibly first week of September, the deaths that we are seeing now has to increase in the same proportion if this goes. And on the other hand, what we are seeing now is still we are able to cater to the deceased in the hospitals. But when those getting infected today or tomorrow, which is about 10 to 12,000, and if we are not doing something seriously now to stop the spread, the deaths will be about 3 times that we are seeing now on 1st of September, maybe about 500 plus deaths. That is our general projection. On the other hand, even we do something today, a drastic step today, those who have infected today would be spreading the disease for next 2 to 3 weeks, at least within their families. And those who get infected today, some of them would go to severe disease and ICUs, oxygen dependency, and a proportion of them would die. So even if we do something today, the trend that we see today is not going to be reversed for at least for 3 more weeks.
Now, Doctor, this is a startling difference in between the official figures of around 3,600 and what you say between 10 and 12,000 a day. How do you all make this calculation then?
Actually, if you look at, when we are looking at transmission dynamics, we generally look at from a given person how many people would actually is possible to get infected. So in anywhere in the world, that is how we think, which we generally call something called a R naught of the transmission rate in a simple language. So if you look at that, why I'm telling this is every day we may be taking and accounting and accommodating to 3,000 to 4,000 people for last so many days. If you look at last 10 days, from starting from about 2,500 to 3,500 day, we are counting, we are taking them to hospitals and we are treating either hospital or at home. But as I told you, gradually this has increased in the actual ground level. Therefore, those who are not accounted for may be not having any symptoms, but they are infected. So they are the people who are wandering around in the community. They may be going to the jobs, they may be going to their business. So these are the people who may be spreading to a third person or a second person or a fourth person on their day-to-day business. That is how this transmission cycle goes. That is why we are telling that generally when we keep this mobility in this current level, there's high possibility that many others get infected. So that is the general assumptions on the epidemiological assumptions that we are taking and estimating things. And this is how across the globe things are being estimated. And if you look at deaths, issue is the proportion of who are getting infected will not have no symptoms. A proportion will get symptoms, and out of this, another proportion would get severe symptoms, oxygen dependency, and need very severe high dependency care. So when the case numbers increase, the numbers who is shifted to symptoms would increase, the numbers who will get severe disease would increase, and so on. And that is how the deaths would increase. And on the other hand, when the numbers of cases are increasing, the capacity of the health system to manage them is not increasing. It will increase to some extent, then it will be stagnated, and there will be burnout among the healthcare workers, then the quality of care would go down. Therefore, many others could die without quality care.
Now, Dr. Manuj Weerasinghe, who is, of course, the head of the Department of Community Medicine, University of Colombo, who's our guest today on Newsline Zoom. Dr. Manuj, can you say to me, is it about right that Sri Lanka has 90,000 hospital beds in total?
Generally, a capacity which has been translated into COVID is around 35,000. For example, for the whole country, in the government sector, we have beds close to about 75 to 80,000 in all the hospitals. But all hospital beds cannot be allocated to COVID. Now the policy is to allocate 50% of beds to COVID, which means the maximum under new directions could be around 40,000. Still, you need to understand a bed is not a bed unless there are healthcare workers, unless there are facilities to cater to the needs of the patient. So in that case, we are almost coming to the ceiling of beds that we have at the moment, unless we have a drastic step to take more beds with HR, with facilities to cater to them. Otherwise, a bed could be just a part of furniture.
Some weeks ago, we had covered events suggesting that the Sri Lanka Army opened a sort of facility in Cedar, I think with 10,000 beds. Now, is that just a place where they can stay, or can they get treatment inside in a place like that?
There has been an increase of or supply of beds through other services, Triforces and others, adding to the existing beds. Those beds mainly are what we are talking about is earlier called ICC or Intermediate Care Center beds. These intermediate care center beds, there are a few places across. Maybe if you look at Sidua, there's a Brandick who have given it. Then there is one or two places in basically in Gampa district, couple of things across the country. Yes. The beds, as I told you, are there for some extent. But the bed itself does not mean that you can admit patients who have symptoms and cater to them. The issue is the main, I would rather say bottleneck or the barrier is the availability of human resource to provide a quality care. For example, you can have a 1,500 bed hospital built up with the facilities given, but there should be trained staff to man it, to look at the patient every day, to do an assessment, and so on. So in that particular situation, we will have a serious issue because our HR is limited, and there is possibilities being looked at to expand that HR. Still, getting new beds alone is not going to be helpful. Secondly, we are talking about ICU bed and HDU beds or high dependent beds. These beds can be maintained only by well-trained people. And you can't train people overnight and open an ICU bed and ask them to man it. It's a different science. So that limitation is coming a serious nature, because now I think there is about 180 beds that has been used up to now, and majority of them are occupied. It's not only COVID dedicated beds. Now there is no other way, but they are encroaching into the other ICUs in major hospitals, which was dedicated to people like who had a road traffic accident and could be admitted. There are people with other diseases, maybe a myocardial infarction, maybe after surgery. All these has been now diverted for COVID, which means there will be a rationing of services to others who are not COVID, but serious patients coming due to myocardial infarctions, serious other diseases, and so on. So you need to understand there is no way we can just expand beds and tell everything is done.
And on that note, Dr. Manuj Weerasinghe, we'll take a short break and take a quick peek at tonight's headlines from Newsfirst's fabulous program, the Primetime News at 9 o'clock. We'll see you on the other side of the break.
News First, Newsline with Faraz Shauketaly.
Welcome back to Newsline Zoom. We are in conversation with Dr. Manuj Weerasinghe, who's the head of community medicine at the University of Colombo. Now then, Dr. Manuj, could you tell us what measures should we be taking and the reasons why we should be taking whatever these measures are?
From what we understand in the ground level, this infection is spreading. So there is no question of telling that these are clusters or whatever. It becomes a joke then. This infection is spreading in the community, and all of us know that somebody known to us or a relative is either infected or has become a first contact care by now. So it's spreading in the ground. So how we are going to stop this spreading? Unless we stop this spreading, unless we reduce the numbers of cases, the deaths will occur and it will rise. So how are we going to do it? What I'm going to tell here is there are different ways different people understand this mobility restriction. The politicians would understand and define it in a way different from how we as health personnel define. For me, I will just give one example of why we ask for very severe restrictions. As I told you, if you look at my predictions that I told you earlier, if you look at for last 10 days, if we think about the average of 8,000 got infected within the last 8 days a day. A day 8,000 for last 10 days means there should be at least 80,000 people on the ground who are infected. From the 10 days of PCR and rapid antigen test, from the official figures, what we know that we have got about 30 to maximum of 35,000 identified. And they have been taken to hospitals or sent home back or whatever. So at least 40,000 more people who have been infected are on the ground in the community at this particular moment, which means some of them may be having certain symptoms and they may be isolated at homes by themselves, or others who have less symptoms or having no issues would be going to work and doing everything without knowing this. So those would generally spread it across the country in no time. To restrict mobility is that those who do not know their infection status, if we restrict mobility to all, then everyone would be within their houses, and the only possibility is that they will only infect their members inside the homes, not anywhere else, which can be tackled somehow. So that is why we are asking, there is no way that we can handle this epidemic without stopping spread. To spread from our own understanding, and all you have seen it, others have seen it, when we are just having guidelines and ask people to do it, it doesn't work. We saw how across provinces people move. You can't enforce it in the way that we have been enforcing it up to now. So what we have to do is have a strict enforcement while key economic activities are going. For example, maybe BOI, within that framework, within that premises, you can do it. Maybe the port and other places does that. But all others has to be at home. To do it, from my understanding, only way is nothing but a police curfew. 2 weeks, so we can reduce spreading for at least 12 days or 14 days, thereby go back to the original capacity that the health can handle. So that is why we are asking for a very strict lockdown. That is one. Second one, I would rather to tell those who are at home, if it is lockdown in that sense, and if the people are kept at home, then police don't need to go and look at whether these people are going all away. They are at home, and it is very easy for health people to manage them, because these identified people are at home. Who are not identified are still at home, and if they get symptoms, the health can respond within a space and a breathing space. So that is exactly what I want to tell, why we want this very strict restricted mobility. You can't stop this infection spreading in the way that you see here. But fortunately, people are understanding it in some way, and they are going to a self-lockdown that you see. Certain towns have been locked down. Nobody has pressured, but they have done it. We see it, some people are not coming, opening their businesses. We know that they have a problem, but they understand better than some of our policymakers that this is going to have a serious effect on those daily living people also if this is going to drag on. So I think that is what I want to very clearly state. We definitely need some severe restrictions at this particular moment. No doubts about it.
Dr. Manuj Weerasinghe, head of the Department of Community Medicine, Columbia University. What about, what do you make of these intermediate care centers?
Yes, I think now, I don't think this name is going to work anymore. There are intermediate care centers were actually developed originally to have people who are asymptomatic to get them from their homes and to keep them to prevent the infection. Now that purpose is gone. Now people are at home who can be home. Only those who cannot be at home because different things are at hospitals unless they have symptoms. Therefore, what we have to do is manage people who are at home. So I want to tell very clearly that they can't be left alone at home. They has to have at least one telephone call a day to assess whether they are well, whether they get symptoms. Do we have to evacuate them early for a treatment center? This has to be done by a medical team through a hotline that is dedicated, and there should be enough staff to handle it. And I would, from last couple of days, we have done a mechanism to tackle all these with all the stakeholders getting in. I hope that that mechanism would be announced by the government late today, how this whole system would operate, evacuating patients from home at the first instance to keeping them at home later and managing them. So I think people have to be a bit alert on the news and the system that will be announced possibly tonight or early tomorrow morning. So that is the message that I really want to give you, because adhere to these instructions, then you will be safe.
And finally, Dr. Manuj, going back to this disparity in the figures, the official figures and the figures that your sort of group of professionals have discovered. Can you very quickly tell us once again, please, how does this disparity happen? Is it because the official figures are deliberately understated, or is it because their mechanism for obtaining the figures is wrong?
I am not going to pinpoint anyone or any party on this, but I have to very clearly state, even in January this year, we saw some of those issues because of there is a problem of having common database and the data flow from the ground to the top. So unless we have that data flow at least established now, these disparities will be there. We had a proposal, actually a team of us in February this year, stating how this whole data flow should be there. It has to be transparent. There will be multiple places that people can enter and look at data and update this data. That data system, unfortunately, is still, I think, is not up to the mark. That is why, if you look at from the provinces would say Eastern Province, we have about 300 odd cases. Suddenly going to the central database, you will say maybe about 20 is reported. There are so many issues in this data flow, and that has to be rectified immediately. We have given the diagram, we have given advice, we have shown how to do it almost now 6 months back. And that is the issue. At least now decision makers have to work on those.
We need a central database from the bottom to the top.
Yes, basically this is a two-way process. This is a two-way process, and at bottom and the top, these channels has to be very clear and transparent on data flow. If not, the same thing could happen in 2 weeks' time again.
Would you agree with me, Dr. Manuj Weerasinghe, when we say, or as the leader of the opposition, Sajid Premadasa, said, Sri Lanka lives matter? Is that the main thing?
Now, the first or the main priority is to save lives. There's no doubt about it. And every Sri Lankan's life matter, and those who are dying is actually unfortunate. I personally feel majority of deaths could have averted if the original vaccination plan, which was stipulated in January, was done to complete vaccination for all over 60 before shifting to other groups. But it was not the case that was operated. and the health professionals regularly, repeatedly emphasize that you should not deviate from the original plan. If we have done that vaccination properly, we had enough time to avert many of the deaths that is happening on the ground now. I'm very clear about it and I'm very vocal about it. We could have prevented many deaths by now if we have done and adhered to the vaccination policy that was agreed upon in January this year.
Dr. Manuj Weerasinghe, Head of the Department of Community Medicine, Colombo University, thank you very much for your time and your expertise and your counsel on Newsline Zoom. We appreciate your presence very much. And that's the way it was on Newsline Zoom tonight. Remember, Sri Lanka lives matter. And do take the advice and the advisories given by the health professionals, because at the end of the day, it is for our collective good and nobody else's. Take care, good night, and God bless.